the net section. Under the net section. Sorry, bro. So under what section? You see where it says net? Up there. You see the boxes? Camera. Underneath it says network. Camera. Okay. Net one. Okay. Okay. See the little computer? Right. Now click on the computer. Oh, okay, good. It's not here. Okay. Let me try. Now go to the computer and click on it when you're done. Okay. You want to make 5.0? Yeah, I'm on 5.0. Now go to IVGA, click on it. Right, I clicked it like 2 times. Right. Right, I'm on 5.0. Right.
Okay, wait, hold on. Where's that? Oh, right here. What the hell?
So, Launchpad. Oh, it's already on the dock, right? So all I have to do is click on it, right?
Right click it off, right click on it and put close or quit.
Okay. Not even doing
Then go to Launchpad, reopen it, relaunch it.
Go up to the top then.
Up to what?
Here.
You go to Launchpad.
Okay.
Right where you at, Launchpad right there.
Right.
Then go to VGAI.
Oh, there you go. Okay.
Is this now? So look for TriCast. Now go to your TriCast and click on it to connect it.
Right. Yeah.
You said you're on 5.0, right?
Yes.
Wi-Fi.
Yes. So yeah,
go to the TriCast and then you can click on it.
She got it. Okay, good, perfect. We got it. Okay. So I'm gonna do this one now. Cut it up. I was proctoring the exam and it's a little crazy here, but all right, I'm gonna start now. Okay.
All right, sounds good.
All right. I'll see you later. Okay, bye.
Let me know when you want to start, because I'll just come.
Okay, yeah,
I'll
that's all
fade in and out your.
That's all I need you to do. Yes. I wish you didn't have class. We could do it together. So.
Are you teaching tomorrow?
Yes.
All day?
All day. So Sam, what she wants to do, but where's my fucking
home?
It's here. Where's my thingy?
Oh my god, my ear hurts so bad.
Okay.
That's the one you want to do?
No. It's on my thing.
No, I'm saying like you want to.
Yeah,
do
that's
it
the
like
one.
that one.
Yeah, that's fine.
So you don't even need this TV.
Right, I don't need it. No. This is such bullshit. I hate fucking Apple. I really do. It sucks balls.
Do you have the slideshow there?
Yeah, it's in here. It says HA.
That's what it's called?
Yeah. HA.
HA what?
Podcast. Oh, HA Chapter 22 podcast.
It's right here. What? There's a problem with the content?
Oh no.
But isn't this a JB slideshow?
Yeah.
So we can get it online then.
No, but I cut it up.
What? Maybe damaged.
Just run it. Okay. There it is. Okay, perfect. Perfect. Right, that's what you see. Right? Is that right?
Do you want me to cut off? Do you want me to cut off the computer or?
No.
You don't even need that. You can't see it.
Okay. Does it look better than the blue? Okay. Right. Let me get that. Okay, good. Okay, just straighten me out here. Don't move me around, I get dizzy. Too big. Okay, I don't care. That's fine. How's that look? Will that mess up the words? Okay. Yeah, I see it. Yes. In, out. Yes, ma'am. Three, two, one. No, gotta do my name first. Three, two, one. Welcome to Almighty TV. I am Hector Arroyo. Today, okay. Ready? Three, two, one. Welcome to OMI TV. My name is Hector Arroyo. Today we'll be going over psychiatric emergencies. All right, as EMTs, we're often called to people's houses or into businesses or wherever we might get calls and get called for behavioral or psychiatric emergencies. Now, these things can be a result of either an acute illness or some mental illness themselves, or maybe people taking drugs or drinking alcohol. A lot of times there is alcohol and drugs involved. Sometimes it's just a person overcome with some stress or some stressful situations. There are pretty few causes that cause behavioral psychiatric emergencies. At some point, all of us will experience some type of crisis, whether that be stressful, depression, especially in this field, right? We get stressed out because of overtime or no pay or long hours. So it doesn't only happen to the general public, but it also happens to us as healthcare providers. So we have to concern ourselves with ourselves first, and then the patient, right? The most common misconception is that a mental or crisis or a behavioral crisis is someone who is really violent or is looking to hurt us or hurt themselves. That's not always the case. In some cases, patient might just be depressed, needing somebody to talk to or somebody to vent with. Things like divorces, loss of a job, imagine losing your income, a death of a family or a friend. Those kinds of things can cause stressful situations in our lives and cause us to be depressed or have some other mental breakdown. All right. Another myth is, again, that people may be unmanageable or violent, and that comes with us being a little more communicative with them and trying to listen to somebody. Maybe sometimes people just need to talk.
we're exposed to a lot of violent patients as EMTs and healthcare providers. Our job is one of support and communication, and really being good listeners. We think that you know, that people are out to hurt us, but that's usually not the case. A very small percentage of people are outwardly violent. For the most part, again, people just, you know, feel a little stressed, and they need to talk things out. As EMTs, we should be good at predicting violence, right? Looking at people, looking at their body language. That tells us a lot about what's about to happen, right? Now, what is behavior? First of all, behavior, who defines behavior? And for most part, behavior is defined by a society or you know, a community. Anything that's becomes out of the norm of normal society usually is you know, called bad behavior, right? Most times people do respond well to changing environments, job, you know, family, things like that. But anything that keeps us from living our day-to-day lives, that pretty much is what a behavioral emergency is. So when it comes to a time when a person can't cope with stresses or job-related, family-related, money-related, whatever they are, that becomes a behavioral crisis, right? There could be some other reasons why people have behavioral crisis. EMS gets called for things like psychiatric patients that may have been, you know, taken home and had a relapse. Maybe the family or the friends are looking at the patients and their behavior is not normal, or they may be acting out and trying to hurt themselves or others. So in these cases, that's how we really define it a behavioral crisis. Obviously, if that person is out to hurt themselves or others, then that's when we get called. For the most part, we get called, and law enforcement gets called if that person is outwardly acting out. So if anybody who's trying to hurt themselves or others, that's really how we define a behavioral emergency. Right? Now, there can be different situations where people have mental disorders or mental breakdowns, right? There's a general anxiety or disorder, which are, you know, anxiety is a real thing. It can manifest itself into physical problems. When's the last time you've had some anxiety, had to take a test, a job interview, and you get a little anxious? Most of us can actually deal with it. It's when the person can't cope with it on a calmer level is that where it becomes a problem. Panic disorders are real also. Social or other phobias, you know, people that are afraid of being outside, or people afraid of being around a lot of people. Those are real things that can show up as physical problems. Post-traumatic stress disorder, which is something we have to work through as healthcare providers, not to mention people like people in the military, which we'll talk about later, and you know, police officers, anyone who has to respond to emergencies, you know, accidents and things like that might remind them of something later on. And some obsessive compulsive disorders are also real behavioral disorders, which people actually deal with on a day-to-day basis, right? But psychiatric disorders are not just standalone things. They usually have something that's underlying, whether that be a social situation, a disease that, you know, that may not be something known like schizophrenia, which is an idiopathic disorder, which means they really don't know how it comes on, but just people manifest their behavior like that. It could be something as simple as a diabetic emergency, which can be treated, or in many cases there are drugs, alcohol that may be involved. So these things are things that we need to understand. Electrolyte imbalances are also a problem with older patients, or patients who are not taking care of themselves, or, you know, renal patients, things like that. right? As an EMT, we're not here to diagnose people's psychiatric problems.
I know you got some slides done, sorry, but there are 4 students looking to retake their OB test. They're fizzed out.
Can you pause it then? Or he's gonna cut it out?
I think we can cut it out, but I have no idea.
Ask Abby, can she do it? Because I'm in here, please.
Okay.
So we're not responsible for diagnosing psychiatric emergencies. What we do is treat the underlying problems, whether that be an organic problem or a functional problem. Now, organic disorders means that there's a disease of the brain tissue itself, right? Things like seizures, traumatic brain injuries, drug or alcohol abuse, overdoses, withdrawals from drugs. Those kinds of things are really problems with the brain tissue itself, or some certain conditions that affect the brain itself. Functional disorders can impair body functions, but really you really can't tell if there's any change to the anatomy. Let's say schizophrenia, anxiety, depression. Those types of things are really not things that we can see on an everyday basis, but they're more like episodes that we may have to deal with. As an EMT, we're dealing with behavioral crises. We're going to take care of ourselves first. That's how we start to manage our patients. Communication, like I said, is very important. All right, in your scene size up, when we're talking about starting our patient assessment, it is essential that you keep yourself and your partner safe. When you're dispatched to such a call, you want to make sure that you are that you know more or less what you're getting into. And like I always say, if you can't make the scene safe, then find somebody that can. Take your appropriate standard precaution like you would with anybody else. Request any additional resources, which is going to be the police, obviously. They're going to be your best advocate. Think about what's going on with this patient. If this patient's not responding to you in any coherent way, maybe you can get family or friends to tell you what's the presenting problem. Begin your assessment. Start to think about the chief complaint. Get a rapid physical exam just to rule out anything physical going on. All right. Try to establish a rapport with the patient. Talk to them, and not only talk to them, but more importantly, listen to them. In some cases, these people just need someone to talk to, and that could bring down some of their anxiety. Right. Obviously, airway, breathing, circulation, those types of things we're going to look on every patient. This patient, unless he's unstable medically, you're gonna probably be there for a while, at least to try and calm his stress, or try to listen to what's going on with him. Investigate your chief complaint. Think about what's going on with this patient. Again, your advocate, use them all. Your family members, your friends. Is the patient having a central nervous system functioning problem? Did he have an injury to his head or his spine? Is he hallucinating? Are there drugs involved? Alcohol involved? All right, look for drugs or drug paraphernalia in the living room or wherever the patient resides. Have there been any significant life changes? Those are absolutely good questions to ask. Is this person just recently divorced? Did they break up, a relationship? Did they lose their job, lose their income? Did somebody die that was really important to them? These kinds of things can trigger a behavioral episode, right? In your sample history, that's your chance for you to start being able to get information from that patient, past information. Maybe they've had a recent or past psychiatric problem, maybe not, and this could be a isolated episode. So this is when you start to use your communication skills, and mostly your listening skills. Be a reflective listener. Don't look into roll your eyes and don't look into space while people are talking to you, because they genuinely want to let go of some of their stress, and in some cases you may be someone that they can turn to other than their family, right? As you're talking to them, think about things like, are they answering your questions appropriately? Are they talking, nonsense? Do things that aren't relevant? Do they see things? Do they understand you? Are they listening to you when you talk to them? Are they being hostile? Do they are they looking violent? Do they look like they're clenching their fist and biting their teeth and gritting their teeth and things like that? Some of these signs can tell you that this patient's about to be violent. Do they seem sad or depressed, or not being able to communicate, or not wanting to talk with you? These are the kinds of things that as healthcare providers we want to be able to get from the patient. And the more information we get, the better we are equipped to treat our patients, and are better equipped to tell the hospital and get them the appropriate care. On physical exam, you're gonna on an unconscious patient, you're gonna do a head to toe. On a conscious patient, you want to make sure that they start to talk to you. If they don't, then who can you get to help you with that? Well, family, friends. Those could be help. Now, that could be also a bad thing. You can have family and friends that are causing this episode. So the reverse could happen. So if your patient's upset with somebody in the room, maybe you want to get them out of the room so that that person can talk openly with you. All right? In your physical exam, look at their facial expressions. Are they clenching? Do they look like they're angry? Is their pulse rapid? Are they sweating? Are they breathing fast, like they're going to jump at you? So always be careful with that. Keep yourselves between the patient and the doorway, just in case you have to make a quick exit. All right. Your transport decision, this is where you might take a while to be in the patient's house. This is where you want to decide where you're going. And if the patient is not agreeable to going to the hospital, but you feel and the police feel that they need to go, then this is where now you've got to get your whole team together and really decide how you're going to take this patient and where you're going to take them. Right? Most of the times we're going to transport them by ground, because this may not be a critical emergency, but it is a true emergency for that patient. When you're reassessing your patient, once you have that patient in your ambulance, you want to make sure you don't let your guard down, because it could be a little unpredictable. They may be a little anxious during the ride, and that could trigger something. So, make sure that you are watching your patient appropriately, and don't let your guard down. As far as your interventions go, for psychiatric emergencies or behavioral emergencies, for the most part, our care is supportive. If we're talking about restraining a patient, once they are restrained, we want to make sure that they are comfortable, that they are in a good position where you can actually assess their airway, especially, and make sure that no harm comes to them as we're going to the hospital. We want to communicate to our receiving hospital that you may have somebody with a behavioral emergency, and that they may need to go to a special area. Most of the time, if your hospital has a psychiatric emergency, they may go directly there if they have a history. If not, they may need to get cleared medically first. Whatever your local protocol is, make sure that you can deliver the patient to the appropriate facility. Now, in some cases, you may treat an acute psychosis. An acute psychosis is a state of delusion in which this person is out of touch with reality. This is somebody that may be hallucinating, who may be talking things that make no sense at all, and they could be affecting not only themselves, but other people. Schizophrenia is also a complex type of psychosis. like I said before, it is idiopathic, but it does come with certain signs and symptoms like delusions, hallucinations. And as again, as good communicators, we don't want to, go ahead with the delusion, right? Guy says there's a purple elephant in the room. Don't egg him on. Agree. You can agree with him, but don't continue the delusion. In other words, yeah, I see a pink. You see a pink elephant. I don't. You do. Let's take you somewhere where you might talk to somebody about that. All right. So you don't want to keep the delusion going. For other types of psychosis, they may have a lack of interest in any type of pleasure. They may be depressed. They may be talking out of their head, erratic speech, where they're not speaking English even. All right. So in total, what you have to do is determine if this type of patient, first of all, is dangerous to you and your partner, dangerous to themselves or others or to the environment. Again, your communication skills really come into play here. You have to identify yourself, make sure that they know that you're there to help them, not drag them out of the house to a hospital. That you're there to help, you're there to listen. Be calm, be emotionally strong, but be direct, right? Don't let them take you on tangents that you don't need to go on. Be direct with them. Make sure that they're talking to you about what's going on right now. Keep your emotional distance. I know in all our job, we tend to sometimes get into a patient's emotional problems and make them our own. Can't do that. We got to stay really, really away from that, because then you take that problem home with you and it can affect you. Don't argue with somebody if they're telling you they see something and you tell them no, I don't see it. Don't argue with them, because it's only going to escalate the problem. Again, explain to everyone what you're going to do, and before and after you do it, and why. Why are you doing it? Why are you taking vital signs? Why are you checking their respirations? So that you basically what you want is to gain their trust and get a good rapport with the patient. The more information you get, the better you communicate this patient, the more they are apt to tell you, and the more information you can pass on to the hospital. Now, excited delirium. Excited delirium is a condition of impaired cognitive function. This is something that can come on all of a sudden. It can be manifested by disorientation, hallucinations, delusions, or agitation. And that's really where we're kind of worried, the agitation part, because that can affect us directly. So they may have, they may be pacing around, may be doing some erratic behavior, and that's when you want to maybe take a step back just to protect yourself. Always keep your eyes open, keep yourself safe. Again, you have to keep the patient between the door and you, right? Make sure that the door's at your back, the patient's in front of you, so that you can have a good egress. Some of the symptoms of a delirium, excited delirium, hyperactive or irrational behavior. They may see vivid hallucinations. Again, the pink elephant is an example, but it can be anything: people, dead people, animals, anything like that. They may be hypertensive. They may be tachycardic. People that look like they're amped up, right? They could be sweating, dilated pupils. We don't like to use the word crazy, but a crazed look in their eye. Those kinds of things can tell you that they're excited, and they may jump at any time. So as far as we go, we have to keep ourselves calm, present a calm exterior, so that patient knows that you are a professional. Be supportive and empathetic. And we all have our days, and this person may not be able to cope with them. Approach the patient slowly, no sudden movements, because anything like that could start them on a episode. Give them their space, right? Limit your physical contact so that they're not in close proximity to you to swing at you. Don't leave the patient unattended. Don't let them go to the bathroom alone. Make sure they keep a door open, or that a family member is with them, so that they don't try anything in the bathroom, or jump out the window or something like that. These are people that we want to keep a close eye on. Be good, like I said throughout this whole podcast, be a good communicator. But not only communicator, but a good listener. All right. Also, be very observant, because these kinds of things can tell you, give you a hint on what's going on. What's their hygiene like? Are they taking care of themselves? Are they washing themselves? How are their clothes? How do they live? What's their apartment, or what's their room look like? Those kinds of things could tell you that this could be something that's been boiling for a while. Are there drugs involved? And that's very important, because now we'll go on a whole other side of this call, right? Is there drugs involved? Is there alcohol involved? Is this an episode because the guy is drunk or high or overdosed on something? That could be something else, and that turns into now a medical problem. If the patient's so agitated that you can't handle that, then maybe you can call for ALS and get somebody to chemically sedate them, so that then we can restrain them and take them to the hospital. That's a possibility. Use your resources as you see fit. If you can't handle it, don't be a hero, because you could get hurt. Call for somebody that can help you to handle this. All right. Now, we talked about restraints before. In our careers, I'm sure that we're going to restrain a few people. We are not there to restrain anybody, but we can help the police to restrain patients. We can't drag them out of their house, because for us, we leave ourselves open to all types of lawsuits, right? So if you're going to help the law enforcement restrain patients, we're going to talk about doing it humanely, so that you can actually be a good advocate for the patient. Right? People should be properly trained, as should we, in restraining patients. If you think humanely, if you think about being able to assess your patient, you should be able to do a good job. All right? So legal aspects of that, right? We don't want to restrain somebody or drag somebody out of their house that we're not supposed to, right? If anybody, one of the caveats to that, if somebody is a danger to themselves or others, the police can actually restrain them for their own good and take them to the hospital. So again, legally, we don't want to get into this legal issue where we can be sued for assault or battery or false imprisonment. So that's where you have to think really about your certification and about what's the patient's need, and how we get them to the hospital in the safest way possible. Right, so we want to restrain patients or help to restrain patients. We want to protect them and protect ourselves. So that should be something that's a team effort, and it should be a coordinated effort. In other words, everybody moves at the same time towards the same goal, right? If you got to involve law enforcement, then so be it. But make sure that you restrain them in a safe manner. First of all, you want to talk to the patient. Make sure that they know what you're going to do. Even though they may not like it, at least they know that you're about to touch them or grab them or whatever it is. Have your team know exactly what you're doing, right? You want to use 4 or 5 people, one on each extremity, one at the head, and maybe one as a leader. In other words, he's going to call out when we're going to move. All right. There should be a plan, right? Make a plan before you do anything, because if we're pulling in 5 different directions, the patient could get hurt, we could get hurt. All right, so it's important we make a unified, coordinated effort to move that patient. We want to use soft restraints. Okay, we don't want to hurt the patient at all. We want to be able to make sure that we sit them in a position where we can assess their airway, breathing, and circulation. A knee to the chest is not a good way to restrain a patient. It could get us in trouble. It could actually do more harm than good. So we have to factor in all these things. Factor in the patient's age, size, sex. All right. So if you've got a female, or maybe you want to use the same-sex partner, so that that person doesn't feel intimidated. Maybe they'll move a little easier with that EMT, right? But for whatever, however we're going to do this, make sure again we're humane, we're safe for ourselves and for the patient, right? Talk to the patient throughout the process. Make sure they know what you're doing. Don't do any surprise actions, because it could set off another episode, right? Avoid or respect that patient's personal space, but again, we're going to have to restrain them. So be very careful. In some cases, patients may spit or do things. So you want make sure that you, if that's the case, you want to make sure that they have a mask and that you have your precautions, your standard precautions. 4-point restraints are what's preferred, right? Two on the upper extremities, 2 on the lower extremities. Make them soft. Make sure that they're not tied too tight, so that we don't hurt the patient any further. And by all means, en route to the hospital, monitor that patient. For potentially violent patients, which pretty much make up a small percentage of the patients we get during behavioral crisis. These are kind of the exception, not the rule. But in these cases, yes, we might need to use restraints, call law enforcement, being alert about their body language. Remember, we talked about that before. Make sure that they are not, clenching, sweating. If that's the case, and if you feel like they're going to get violent, then back up. Back up and let the people that are there and that are trained to take these people down, let them do that. All right. They may have a history of violence, so that should be something that you're asking in your sample history. Their posture, like I said before, clenched fist, grating teeth. Those are kinds of things that kind of give you a hint that these people are about to get violent. Right? Is a scene. When you get to the scene and you're going back to your scene safety, make sure that there's nothing that the patient can hurt themselves with, or you. Sharp objects, guns, knives, things like that. What kind of vocal activity is this patient? Is he yelling, screaming? Is he being, abusive? Those kinds of things. So make sure that you're aware of those things. And most telling of all, like I said, body language tells us a lot about what's going on with our patient. Are they pacing around? Are they kind of following everybody around, like staring at them? These kinds of things can tell you that this patient is about to get violent. So be careful with those things. Poor impulse control, the history of things like fighting, those are all important. But at that moment, be aware of what that patient looks like, right? Now, let's talk about something that's really important and kind of under taught, and that's things like suicide. There are a few age groups that have a high risk for suicide. Talk about your teenage kids, college kids, and then your elderly. Those types of people are prone to suicidal thoughts and suicidal actions. Because depression is a really, really significant factor in these types of activities. It's common misconception that people threaten suicide never committed because they're looking for attention. That's not true. People that do verbalize suicide should be taken seriously. It should not be just tossed aside without any thought, because they are more prone to these types of situations. So when we're talking about suicide as an EMS call, and you're getting a history, talk to the family. Find out if there have been any suicidal thoughts. Has this patient been depressed? Have they been down? Have they lost a job? Are they not feeling or acting the same as usual? Do they not talk about things like the future? Are they talking about things like suicide, which is something that's not normal for a teenager, for a college kid? This is somebody that's got their future ahead of them. In the case of elderly patients, we're talking about people of 50s, 60s, maybe 80s. But you talk about people in the 50s, 60s, maybe they've lost their jobs or divorce or death in the family. Those kinds of things can trigger suicidal tendencies, right? So depression at any age can actually trigger these thoughts. In our history, we should start to think about people who have tried suicide in the past. People who've tried suicide in the past make up about 80% of the people that are successful with suicide. Are they feeling depressed? Again, have they lost a job, a relationship? Have they been diagnosed with a terminal illness? Those types of things can really trigger some suicidal thoughts and really make some push depression over the edge to suicide. So consider things like a lot of pills around, or something that's dangerous, things like weapons that maybe a patient or a person's never had before. Is their patient environment unsafe? Are they taking unusual risks? Are they not talking about futuristic events like weddings or jobs or careers, things like that? Is there an imminent threat to others, to you, the patient, or others? Remember, people that verbalize suicide probably have no problem with homicide. So be aware of that. Be safe, right? Does this person have an underlying medical problem? Is there any cultural or religious things that may come into play here that can cause them to think about suicide? In some cultures, if you shame your parents, you may have to commit suicide according to their culture. So those things, those can be also factors in somebody trying to hurt themselves. All right. Now we talk about something really important as far as we go as healthcare providers, because post-traumatic stress disorder is a very real and very important subject when it comes to us, the healthcare providers. We see things, we smell things, we hear things on an everyday basis that might affect us later on. We also talk about the military and our veterans who've been in overseas in wars. They've seen, they've heard, they've done things that may come back to haunt them later on. PTSD, very real. It can be triggered by things here back at home, or such as smells, sounds, something they've seen that could take them back to a previous time and trigger some bad feelings. And some of the symptoms of that is helplessness, anxiety, anger, fear. Some of our vets haven't gotten over coming back from being in combat, and those kinds of things sometimes are overlooked because they're military guys, they're strong, and they're supposed to be indestructible, and in those cases that may not be the case. All right. So people with PTSD may avoid things like trauma calls. For ourselves as healthcare providers, we may get anxious at trauma calls or at pediatric calls because we've seen so much death and blood and things like that. So these people may be, so anxious that they may they may be constantly, feeling anxiety. They may have thoughts and flashbacks that can take them back to where their previous incident. Veterans have an increased risk of suicide because of these things. Again, that feeling of helplessness, depression, those are all real things that can manifest themselves into very dangerous feelings. You also can, those mental feelings can also manifest themselves into physical problems, like hypertension, anxiety, those types of things. As far as caring for our combat veterans, all right, we again, with most of our patients, but in particular with these types of patients, we have to be empathetic. We have to be good listeners. Be careful how you phrase your questions. Use a calm but firm voice. Be professional at all times. If I can tell you anything about being a healthcare provider is be professional. The amount of respect you get really comes with the amount of respect you give. Limit how many people involved in your questioning. If their patients are more comfortable with a family member, fine. But we don't want this to become a whole show with a lot of people there. You should ask about patients who are, do they have suicidal tendencies? Are they thinking about it? That's a real question, because they may need to see somebody, and they may need to just get that out. All right, so again, ensure that there are no weapons involved, that you have no weapons, that anything dangerous is around, just for your safety and the patient's safety. And you know, these types of patients you might not want to restrain because it could escalate things. So really, our job is to get a good rapport, to talk to them, and to most importantly listen to them. Our job may not be, you know, putting on oxygen or stopping bleeding in these types of cases, but we can do a lot by just listening. All right. So the legal aspects of all these types of patients come into play because of the fact that we might have to restrain them, but that they may not understand what's going on, that they may be a danger to themselves or others. So patients like this may resist care, and competent adults have the right to refuse care. But in this case, our job is to make sure that they don't hurt themselves or others. Again, never leave a patient alone. If you're in the back with a patient, I would suggest that same sex is preferred, so that we don't get into those types of issues legally. If you don't feel comfortable with a patient in the back of the vehicle, then get law enforcement. They're there to protect the patient and you. Remember, consent. Consent can be expressed, right? And consent can be implied. Implied consent means that this patient, if he were in his right mind, would want to be treated, right? There are also, you know, sometimes as far as psychiatric and behavioral patients, consent may not be as clear cut as normal. It could be somebody, you know, doesn't want to go to the hospital and their family wants them to go to the hospital. This is where things get a little cloudy. So again, your resources are your best advocate, whether it be your medical director, your supervisor, and ultimately law enforcement. If you're not sure, err on the side of getting help. Don't make these types of decisions on your own. Make sure that you can you make these decisions informedly and with the right personnel. All right. The EMT really has limited legal authority to require a patient to go to the hospital. Right. As an adult, we have the right to. Any competent adult has the right to refuse care, even if we call 911. But in these types of cases, it may be for the patient's own good, whether it be the family that wants them to go to the hospital, or somebody who may think that this person may be a danger to themselves. So be aware of that stuff, right? A court of law would probably consider your actions if you take that patient without their consent battery, assault, unlawful imprisonment. So really maintain a high index of suspicion for your patient's condition. Really, what I tell you about this, the takeaways from this whole podcast and from this whole chapter is your safety comes first, your partner's and yours. Make sure that you are safe. Make sure that your patient is safe. Use as many advocates as you can, bystanders, friends, but most importantly, your supervisors, doctor, your medical director, and law enforcement. Those people are there to keep you safe. Don't make these decisions on your own. All right? Err on the side of treatment and transport. All right? When you're not sure, then take them to the hospital. All right, so this is the end of Psychiatric Emergencies. I hope that you took something away from this chapter. Stay tuned for more. Thank you. Have a good day. 3, 2, 1, cut. Yes.
What chapter?
Chapter 24. I did 23. That's GYN. It's already done. I want to see the other one, but... Huh? Okay, later. Huh? Yeah. I don't know, can you look back at it a little bit? Am I looking straight? Come on. Can you look at the other one for a minute? Okay. I was looking at the camera, so. That's fine. You can't see but you can see the computer. But my head's too low. Am I slouching? No, right? Okay. Does this shirt go with that background? Okay. Come on. All right. Come on. This chair digs into the thing. Yep. Ready? Come on. I know I do. Yeah, like my head is not round. It looks oblong. No. Come on. If I was that thin, I don't know. Just put my whole head in the screen. Oh man. I don't know, but you messed up my head and my body. My head is huge. No. My head is huge. Straighten me out there. No, my head is big. Start from the beginning again. What?
I don't know what I did to your head. I can't. I have to exit out and go back. What if I turn the camera off? You think it'll work? Let's see. Oh man, that is funny stuff. Where is the button?
For what?
Turn it off.
Oh, on the other side. You gotta power off the camera?
Yeah, to see if that'll help. Turn back on.
I don't know. I'm gonna look straight. How about now?
No, I'll exit.
All right.